Professor Alpha Fowler, who is the professor of medicine, and he'll be talking about the intravenous vitamin C, pathway to a new therapy to save lives. He has got extensive work, he has done extensive work in this field. Along with him, we have got other panelist, Dr. Pradeep Rangappa, who doesn't require any introduction. He is in Bangalore. Dr. Prashant Nasa, who is in Dubai, Abu Dhabi. Dr. Anup Kumar AS, who is in Calicut, and Dr. Bharat Kumar TV, who is one of the lead author or lead investigator of the Lovett trial for vitamin C. So first of all, I'd like to give introduction of Professor Alpha Fowler. Professor Fowler is working as Professor of Medicine in the Division of Pulmonary Disease and Critical Care Medicine at Virginia Commonwealth University School of Medicine, USA. He has been studying sepsis-related acute lung injury and its vascular pathology for over 30 years. And at least 13 years now, he has been actively involved in basic laboratory and clinical research on vitamin C, its role in sepsis and pneumonia. He was the principal investigator of the landmark CITRIS-ALI study, which has been published in JAMA in September 2021, a multi-center national heart, lung, and blood institute supported trial using high dosage intravenous vitamin C in critically ill septic patients who developed ARDS. Dr. Fowler is further studying intravenous vitamin C infusion in the patients with COVID-19 lung injury. He has, to his credit, more than 140 peer-reviewed publications. As we all aware, several recent RCTs on had therapy in sepsis using low dose of 6 milligram per day of IV vitamin C in combination with hydrocortisone and thiamine consistently failed to show any benefit of mortality reduction. Whereas CITRIS-ALI study using high dose of 200 milligram per kg per day of IV vitamin C, which is equivalent to 10 to 20 milligram per day for 50 to 100 kg person, as monotherapy showed a mortality reduction. So let us not wait. Let us hear from the mouth of the researcher only, Professor Fowler. Welcome, Professor Fowler.
Thank you very much, Dr. Govell. I really appreciate the opportunity to come and speak with you, even though we're doing it virtually. What I would like to do in the next few minutes, I would like to relay in a way the approach that we took to developing a protocol for administering vitamin C intravenously in a protocol that we feel is very successful at bringing patients with sepsis and septic shock who have developed acute lung injury, acute respiratory distress syndrome. And so for the next few minutes, I will be speaking about the work that we have done in this area. And I would like to thank you very much again for the invitation to speak. In the United States, which is a smaller country compared to India, we have approximately 334,000 patient population in the United States. And among our population, bacterial sepsis occurs in about 1 million people every year. 35 to 40% of septic patients will develop some form of acute lung injury, acute respiratory distress syndrome, and 30 to 45% of those individuals will die of acute lung injury. If you focus on these two Boeing 747s, we know that a fully loaded Boeing 747 will hold 416 passengers. Two fully loaded 747s will hold 832 passengers. And if you can think about two Boeing 747s crashing every day, that is how many people in the United States population die of sepsis each day of the year. That is approximately 2 deaths every 2 minutes. And this amounts to approximately 300,000 US citizens that die of sepsis or sepsis-related acute lung injury. You may or may not recognize this name, but this Muhammad Ali was a great champion prize fighter in the United States who died of sepsis and probable ARDS in June of 2016. This individual, Paul Allen, was one of the co-founders of Microsoft with William Gates. And he had developed leukemia, was admitted to a hospital, neutropenic, and died in septic shock in October of 2018. Globally, the annual incidence of sepsis and sepsis-induced acute lung injury occurs in approximately 51 million people. This has been from one of the global trials in first and second world countries, but in third world countries where healthcare is very poor, the incidence is probably untold. Approximately 10% of patients in the United States admitted to intensive care will develop ARDS. Acute lung injury mortality, 35 to 45%. Patients who survive to discharge, as many of you know, have long-term morbidity, disability, and post-traumatic stress disorder. The important figures in the United States, 33% ARDS and sepsis accounts for 33% of ICU patient days, 24% of hospital charges among intensive care unit patients. ARDS and sepsis are among the costliest ICU diagnoses. And in US intensive care units, the cost is approximately $40,000 US per day of intensive care. In the next few minutes, I'm going to be talking about events that occur at the alveolar capillary membrane. If you were to take a cross-section across this unit of the lung, we would come up with the alveolar capillary membrane. We have the dry airspace of the lung, and we have the capillary perfusion network of the lung. The important thing about the lung is the lung barrier function prevents, under normal circumstances, plasma from entering the dry airspace of the lung. This series of images is a 29-year-old woman with metastatic ovarian cancer who was admitted in septic shock into the intensive care unit when I was attending physician several years back. And you can see the progression of chest films as the lungs began to gain water. And this woman ultimately survived, but after more than 4 weeks on mechanical ventilation. The problem, as you can see here, is that for a protracted period of time, the lung gains water into the airspace that is very difficult to remove. The ongoing theory concerning how the alveolar capillary membrane is broached is that activated neutrophils sequester in pulmonary capillary network of the lung, secreting proteases, generating reactive oxygen species, which damages the alveolar capillary membrane, allowing neutrophils to migrate into the alveolar space, and for the alveolar space to be flooded with plasma. And if we do bronchoalveolar lavage from this environment, we find that there is a significant generation of reactive oxygen species, hydrolytic proteases, pro-inflammatory lipids, pro-inflammatory cytokines and chemokines, and very importantly, which I'll mention in a few moments, cell-free DNA, which is very destructive both to the alveolar environment and to the pulmonary capillary network. So, for the most part of my career, which is now close to 50 years, During the active research, I have always had an interest in sepsis and in septic acute lung injury, as we all know as ARDS. And despite 50 years, 5 decades of basic and clinical research, we still show that effective pharmacotherapy has been very elusive. As you all know, prior to the onset of admission to a hospital, there is a period of risk which occurs anywhere from 1 to 3 days as sepsis is developing. And during this period of time, immune cell activation occurs in the microvasculature. Microvascular thrombosis begins to mount as bacteremia, endotoxemia, and cytokine surge. And ultimately, clinical recognition of organ injury occurs, and the patient, for the most part, crashes into critical care and into your care. We, as I mentioned, my colleagues and I have had a long-standing interest in sepsis. And approximately now 15 years ago, we developed a model in wild-type mice by simply, and this is a model of surgical sepsis in the mouse, by going to a mouse cage, pulling out 50 or 70 pellets, feces pellets, putting normal saline into a tube, sonicating the tube till it became a ground up mesh of brown. We then centrifuged that to clear the fluid, and then took the fluid, put it into a refrigerator overnight. And then on the day of creating the model in animals, we would inject each animal with 1/10 of an ml of that, what we call stem solution, and studied the mice as they developed sepsis over a 20-hour period. And it was on the mice that we had studied approximately a 100% mortality within 24 hours. And in this population of mice, we did detailed study of the lung tissue. We also carried out studies in mice where we produced sepsis by injecting the organisms intraperitoneally. And then 45 minutes after the onset of sepsis, we injected intraperitoneally 200 micrograms per gram of body weight of the mouse. And then these mice were allowed to incubate for a period of 20 hours. And then we performed detailed imaging of the lung tissue in these mice. In the mice that were what we call control mice, that were surgical septic mice, we see that there is intense cellular infiltration in the lungs of these mice. And if you see this amount of proteinaceous debris, all of these mice had developed acute lung injury. In the mice that we treated with vitamin C at 200 micrograms per gram of body weight as a one-time injection, you can see the difference in the cytomorphology of the lungs of the treated mice. We also stained lung with a monoclonal antibody to a surface receptor on mouse neutrophils. And you can see all of the brown shows that in the untreated mice, there was intense sequestration of neutrophils in the lungs of these mice, whereas in the vitamin C treated mice, there was virtually no sequestration, such that vitamin C and the dosage that we tried in these mice attenuated the neutrophil sequestration in mice. The other important thing we found when we looked at whole lung and stained for microthrombosis, everywhere there is an arrow here, was microvascular thrombosis. So septic murine lung contained a lot of microvascular thrombosis. In the lung of vitamin C treated septic mice, there was a dramatic attenuation with only one thrombus detected in our studies, and this was repeated several times. So what we knew was that vitamin C in these mice would attenuate infiltration in the lung. It would attenuate the thrombotic complications of sepsis in the mouse. And so then we moved to trying to determine some of the inflammatory mediators in the lungs of mice using quantitative polymerase chain reaction. And what we did was we quantified the messenger RNA of two very potent chemokines in the mouse, one KC and the other determined LIX. And if you look down here, in a control lung of a mouse, there's virtually no detectable KC. In the feces-induced peritonitis mice, there is a dramatic increase, statistically significant, in the feces-induced peritonitis. In the mice that we treated with vitamin C, the septic mice had virtually no KC that accumulated. And in the oxidized form of vitamin C, dehydroascorbate, it also had a similar effect. And in the LIX mice, the other very potent chemokine, feces-induced peritonitis induced dramatic expression, which was attenuated by both forms of vitamin C in these mice. Something that you may not be aware of, I would like to talk about neutrophil net formation as a consequence of neutrophil activation, the so-called neutrophil extracellular trap formation. When neutrophils are exposed to bacteria or fungi or inflammatory cytokines, endotoxin, we know that neutrophils become activated to generate reactive oxygen species. But within the past few years, it's been recognized that as neutrophils are activated, the DNA begins to unwind and exert pressure on the neutrophil such that the neutrophil extrudes its DNA and all of its reactive enzymes that are ongoing and active into the extracellular space. And so neutrophils that are being sequestered in the capillaries of lung and other capillary networks throughout the body are not only generating reactive oxygen species, but they're generating potent neutrophil nets, which is a newly discovered pro-inflammatory effect of neutrophils extruding their DNA and their enzyme systems. In this series of images, we can see how vitamin C affects neutrophil net formation. These are human neutrophils at 20x and 60x magnification. We then expose neutrophils to a stimulus which would make the neutrophils explode and form neutrophil nets. Here is what the nets look like at a low power. Here are the nets at a high power, so you can see the neutrophils extruding their DNA into the extracellular environment. But here, both at a 20x and a 60x, are 4-ball myristate acetate treated neutrophils that were exposed to vitamin C. And you can see that we totally attenuated the formation of nets in these inflammatory neutrophils. That will become very important in a moment when I tell you some of our results. The important thing that you may or may not be aware of, and this is work that dates back into the 90s, where Borelli and colleagues actually found that subnormal levels of vitamin C in plasma was a constant feature of patients with sepsis. Vitamin C levels that they found, and also in subsequent work, low vitamin C levels correlate inversely with the incidence of multiple organ failure, which means low levels of plasma ascorbate, higher numbers of organs failed. and plasma ascorbate levels correlate directly with survival. Low levels, low survival. And this has been repeated over and over again in the literature that has come down through the years. So to summarize the work that we had done in mice, I want to reemphasize. In our septic mouse studies, we found that vitamin C significantly lowered lung cytokine and chemokine expression, pro-inflammatory peptides that produce a lot of vascular injury. We showed in these mice, septic mice treated with vitamin C, that it reduced neutrophil infiltration in lung. We reduced neutrophil extracellular trap formation in the lungs of septic mice. I'm not showing any evidence, any data on that, but it's in our literature. But I want you to also notice we did extensive study in creating models of alveolar fluid clearance. And we showed that vitamin C significantly increased alveolar fluid clearance and promoted barrier function in the lungs of septic mice. We took this data into the hospital in a phase 1 safety trial, basically using a protocol of administering 50 milligrams per kilogram of body weight infused over a 30-minute period every 6 hours around the clock for 96 hours. And what we showed in a small initial trial was in septic patients with acute lung injury that vitamin C would reduce organ failure, the so-called SOFA score, sequential organ failure assessment score that everybody employs in understanding the extent of injury in septic patients. And we found C-reactive protein and thrombomodulin were reduced. The rationale for administering vitamin C intravenously was worked out very carefully by Dr. Patiotti and colleagues who worked in the laboratory of Dr. Mark Levine at the NIH. And what they showed was, if you look down here where it says oral, that you could give very high doses of vitamin C orally and never really have a very large plasma level. This is 200 micromolar. And you can see metabolized over a period of 6 hours here. But when vitamin C is intravenously infused, the plasma levels can go very high. And so in this insert here, here is oral, and here is intravenous administration into human volunteers in Dr. Patiotti's study. And this is from 2004. When vitamin C is infused into the circulation, what happens is vitamin C initially and almost immediately binds to molecular transporters, sodium vitamin C transporter 2. Once the binding occurs, it is very rapidly internalized across vascular endothelium, across the alveolar epithelium, and we have data to show that infusing vitamin C intravenously, vitamin C is rapidly moved into the alveolar space. And so all of the data that I presented to you, there was a rationale for giving intravenous vitamin C in septic lung injury. And that looks something like this. When sepsis occurs, neutrophils are sequestered, as I mentioned. Neutrophils migrate into the alveolar space, and plasma floods into the alveolar space. When vitamin C is infused, it makes its way into the alveolar space and effectively reduces the fluid in the alveolar space by increasing alveolar fluid clearance. We have shown very carefully that the water channels in the alveolar type 1 and type 2 epithelium are significantly increased in expression, more than 400%, which would allow the alveolar space to clear fluid. And in addition, there is an antioxidant effect. We have also shown in our research that vitamin C downregulates the transcription factor, nuclear factor kappa B, which promotes expression of inflammatory chemokines and cytokines, that it enhances water channel expression, and as I mentioned, enhances alveolar fluid clearance. Approximately now 9 years ago, the National Heart, Lung, and Blood Institute put out a program they entitled the UM1 program. The title of the program was Novel Therapies of Lung Disease. What they were wanting was a phase 2A multi-center proof of concept trial. They wanted to demonstrate efficacy as far as physiological and biochemical endpoints, but not clinical endpoints. They wanted the UM1 to be a multi-center trial on well-characterized subjects. They wanted novel immunomodulating therapy for acute lung injury, and they wanted a common drug with low toxicity. And we began looking at our basic research. We began looking at the phase 1 safety trial that we had completed and put an application into the NIH proposing the vitamin C infusion for treatment in sepsis-induced acute lung injury. And as you all know, the CITRIS-ALI trial that we completed over 7 medical centers. It was, as I mentioned, a multi-center trial. Virginia Commonwealth University was the lead center, the Cleveland Clinic, and a large medical center, the Fairview Medical Center, that is owned by the Cleveland Clinic, were enrollment sites. Also, the Medical College of Wisconsin in Milwaukee, Wisconsin, and a large medical center there in Milwaukee, St. Luke's Medical Center, was another enrollment site. The University of Kentucky was an enrollment site, as well as Emory University. So we had 7 enrollment sites for patients who were septic, who had developed acute lung injury, ARDS, and who were entered into a randomized control blinded phase 2A trial. We proposed as our primary outcomes the sequential organ failure assessment score between 0 and 96 hours, plasma C-reactive protein and thrombomodulin levels between 0 and hour 168, which was 7 days. And as secondary outcomes, we proposed ventilator-free days, ICU-free days, hospital-free days to day 60, as well as all-cause mortality to day 28, and not listed here, also to day 60. We proposed using the sequential organ failure assessment score, as you all are aware and use probably daily in your critical care practice. The inclusion criteria for this study were patients with severe sepsis, patients who had developed ARDS with a PaO2-FiO2 ratio of less than 300. An endotracheal tube had to be in place. Chest imaging had to show bilateral opacities in the chest. ARDS criteria had to be met within a 24-hour period. So it was acute in onset, and there could be no evidence of left heart failure. We excluded patients who were allergic to vitamin C. We actually had 1 patient that was allergic to vitamin C and was excluded from the study. If we could not get consent, patients would not be randomized into the study. If ARDS developed over a prolonged period of time, patients were excluded. Pregnant women were excluded. Patients on home mechanical ventilation were excluded, and patients who were moribund and not expected to survive were also excluded from the trial. We screened 1,262 patients. 1,092 subjects were excluded for a number of reasons. The most common reason was the inability to obtain informed consent. That left us, out of this total, 170 patients that were randomized to receive either vitamin C or placebo. After randomization, we discovered one patient in the placebo group who had acute eosinophilic pneumonia, and this patient was taken out of the trial before vitamin C was administered. And in the vitamin C arm, 2 patients with leukemia had diffuse alveolar hemorrhage and were taken out of the trial. Neither of these represented sepsis-induced acute ARDS. That left 83 patients that were placebo patients and 84 patients that were in the vitamin C arm, and we were blinded completely during the trial. Patients randomized to the vitamin C arm received 50 milligrams per kilogram of vitamin C every 6 hours for a total of 96 hours. And as Dr. Goville mentioned, this amounts, according to body weight, anywhere from 10 to 20 grams of vitamin C in the vitamin C arm treated patients. And this is each day for a total of 4 days. The plasma vitamin C levels we quantified over the course of the trial, and you can see a very significant rise in the plasma vitamin C levels. The normal vitamin C from a normal diet in a human being is approximately 70 micromolar. And in the septic patients who were admitted, you can see there was a very dramatic reduction in the plasma vitamin C levels. And this has been well studied in the past. That's been shown that during the development of sepsis, vitamin C is oxidized. And the quantity of vitamin C in patients that had normal diets dramatically is reduced. And we would typically see baseline septic vitamin C levels at about 15 to 20 micromolar. And you can see the rise in plasma vitamin C levels during the 96 hours of infusion. And then this is out to 7 days. There was still a slight elevation over the next 2.5 days that occurred in patients treated with vitamin C. So when we analyzed the data, we did not have good advice initially how to analyze the SOFA scores, because we initially only analyzed the SOFA scores on the patients who survived. And so that produced a survivorship bias. And over the course of the 96 hours, because of this analysis, we did not show any significant difference in patients treated with vitamin C or the placebo patients. And this was the analysis on the survivors. After we published in JAMA in the fall of 2019, we immediately got letters to the editor telling us that we had analyzed the data incorrectly. And a long letter from Dr. Jean-Louis Vincent, who is one of the top sepsis researchers in the world, told us exactly how he would propose that we analyze the data, and I will show you that in just a moment. We did not see differences in C-reactive protein over the course of patients treated with vitamin C, nor did we see a difference in thrombomodulin in patients treated with vitamin C versus placebo. But we did see a significant drop in the cell-free DNA content in the plasma. And for those of you who follow the critical care literature very closely, you know that cell-free DNA has been found to be one of the biomarkers that will predict mortality in patients with sepsis and septic acute lung injury. And we have a publication that is now pending where we quantified the plasma levels of cell-free DNA and one of the components of the endothelial glycocalyx, syndican-1, showing a significant impact and reduction of cell-free DNA, as well as syndican-1 in patients treated from the CITRIS-ALI trial. Here is the ventilator-free day count. The patients treated with vitamin C clearly had a trend towards significance, although the data did not bear significance, although you can see the difference in the vitamin C treated versus the placebo patients. We did find, however, that patients treated with vitamin C had a significant increase in ICU-free days compared to placebo. And importantly, a significant increase in hospital-free days out to day 60. Here's the Kaplan-Meier curve from our study. If you focus for a moment on the orange column here, you can see the mortality over the first 96 hours between vitamin C treated patients and the placebo patients. In that first 96 hours, only 4 patients died who were treated with vitamin C versus 19 patients who died who were placebo. And then the Kaplan-Meier curve all the way out to day 28. In the placebo patients, we found a 46% mortality versus a 30% mortality in the vitamin C treated patients. And this was, as you can see, it was highly significant. So our protocol, 50 milligrams per kilogram intravenously, infused every 6 hours for a total of 96 hours, significantly had an impact on survivorship. When we used the method for getting around the survivorship bias, using a well-accepted worst rank, best rank technique, we did find that vitamin C significantly lowered organ failure in patients treated with vitamin C at the 96-hour time point. So not only were we able to help patients survive, we had a rationale in that we could decrease organ failure significantly in these patients. So in summary, using the protocol that we developed at Virginia Commonwealth University, where we are administering high-dose vitamin C, we found it is perfectly safe to administer to patients with critical illness. Vitamin C that is prepared for intravenous infusion is very carefully pH balanced. This is usually with sodium hydroxide by the manufacturers. The modified SOFA score in survivors in our study was not different. We did find, however, a significant effect of vitamin C on ICU-free days, hospital-free days, 28 and 60-day mortality, and importantly, on the 96-hour modified SOFA score, modified meaning that we took the cerebral component out. When we adjusted for mortality, vitamin C significantly reduced organ failure. Our future directions are already in progress with a trial that is now about, actually is now enrolling through the Prevention and Early Treatment of Acute Lung Injury Network, the so-called PEDAL network in the United States. We are now testing the VCU protocol over a period of 5 days in a new sepsis trial. We want to know, even now, optimal dosing, what is the effect on post-ICU care, and a cost-benefit analysis As I mentioned here in the United States, the cost for critical illness is absolutely crazy. I want to just show you a couple of cases of where we use the VCU protocol. This is a young woman who had developed enterovirus-induced ARDS that she contracted while on spring break in Italy and returned to the United States, had developed ARDS and required extracorporeal membrane oxygenation support. On day 2, in this patient, we started high-dose vitamin C, and by day 4, you can see alveolar fluid already clearing from the patient's chest. Here is day 7, and on day 7, the patient was extubated, and here is the 2-week later follow-up chest film in the patient who had returned home and who was on room air. And then my last case, this is a surgery resident who developed sepsis and ARDS. And on day 4, we were called to give the patient vitamin C, and it very significantly reduced alveolar fluid, and the patient was extubated by day 7, only to develop strep sepsis again after returning to clinical work, and developed ARDS a second time. Again, we gave vitamin C infusion starting on day 4, and the alveolar fluid and sepsis cleared, and the patient survived both of these events. Finally, I would just mention, I am just the representative of a large team of people who helped to produce the CITRIS-ALI trial. My colleagues that worked very hard at Virginia Commonwealth University, my colleague, some of you may recognize the name Jonathan Truitt, his colleagues at the Medical College of Wisconsin, my colleagues at the Cleveland Clinic, the University of Kentucky, Emory University. And I want to also point out the support for almost $4 million that we got from the National Heart, Lung, and Blood Institute to conduct the CITRIS trial. We also were supported by the Kenneth and Diane Wright Center for Clinical and Translational Research at Virginia Commonwealth University. And then finally, I would like to introduce you to the name McGuff Pharmaceuticals, who supplied us with all the vitamin C product that they make called Ascor. And I think I'll stop there, and we can just take the next few minutes for any question you would like to ask. And thank you again very much for the honor of presenting to you.
Thank you, Professor Fowler, for excellent talk. I welcome Dr. Apur Bora. He has also joined from Guwahati. So now we are having few question and answers.
Any question, please?
Yeah, many questions are there. Can you switch off your screen sharing, Professor Bora, Professor Fowler?
Under Q&A?
No, can you? Yeah.
Okay.
So,
did we use thiamine? We did not use thiamine.
I couldn't follow, sir.
We did not use thiamine. The question was, did we use thiamine? We did not use thiamine.
Yeah. So there are many questions in chat box also and in Q&A.
All right. Is that?
So you have not used thiamine. Did sepsis markers decreased after treatment with ascorbic acid?
The most effective effect that we found in our studies as far as sepsis markers was significant reduction in plasma cell-free DNA, which is a marker of the severity of injury, and a significant reduction in a component of the endothelial glycocalyx, syndican-1. And that is an article that's been submitted for publication. We're waiting to hear right now.
So one question is, shall we use in septic shock or in ARDS or only in ARDS? Person is talking about the vitamin C.
Yes, and let me speak to that as well. I would say yes to using it in patients with septic shock. One of the things that intravenous vitamin C does is it helps to renovate the body's endogenous production of norepinephrine. It is a cofactor for the production of norepinephrine. And in the patients that we studied, adrenal gland output of norepinephrine increases. And I cannot tell you the number of times that I've gone by in the intensive care unit, a patient receiving vitamin C, and nursing comes out and says, I was able to get the Levophed off this patient 2 hours ago after we started your study drug. So I'm a proponent of giving it in early septic shock.
Okay, sir. So another question, sir, please again say about the dose of oral and IV vitamin C.
Okay. Oral vitamin C does not produce an effective plasma level. The protocol that we developed at Virginia Commonwealth University gives a plasma level of about 5,000 times the level from a normal diet. So we would typically get a plasma level anywhere from 1.5 to 5 millimolar. And the protocol that we developed here, the higher the plasma level, the more effective it is in treating the septic process. So giving, as you mentioned when we started, giving only 6 grams, which is 1.5 grams every 6 hours from the various vitamins trial that and other trials that just use the HAT protocol is not effective, and that the dosage of intravenous vitamin C is very important.
Yes, sir. And another question is, any adverse drug reaction of high dose of vitamin C?
We have now studied at VCU over 500 patients, which includes patients that we now have in a trial who have COVID pneumonia. We have seen no adverse events. And we have tracked the oxalate production in the urine of these patients. Oxalate excretion does rise, but we have seen no formation of any oxalate stones during the 4 or 5 days of active intravenous vitamin C treatment.
Another question, does acidic status affect the efficacy of IV vitamin C?
I'm sorry, ask that again.
Does acidic status affect the efficacy of IV vitamin C? I think it's a Jacob Verkes, he's asking this question. Probably he wants to say, in presence of metabolic acidosis, is the IV vitamin C, the efficacy is changed or not?
I can just tell you, we've given it to dozens of patients who are septic and who have lactic acidosis. We have seen no problems. The vitamin C, as I mentioned earlier, is very carefully pH balanced. The product that we were using in the CITRIS trial is produced by McGuff Pharmaceuticals in Santa Ana, California. And it's very carefully pH balanced to about 6.5. And so in patients who have lactic acidosis and sepsis, we have never seen an issue administering vitamin C using the VCU protocol.
Dr. Prachi Sathe want to ask, how did you arrive at 15 milligram per kg dose?
We sort of backed into it. I have no idea how we did that. I mean, we sort of, I mentioned the mirroring studies that we performed, and we just said, okay, let's just sort of equalize this out to human beings. We gave 200 micrograms per gram of body weight of the mouse. And so we just said, well, let's just give 200 milligrams per kilogram of body weight in the human over a period of hours. And so we just simply backed into it just by happenstance. And it was not scientific.
Dr. Simran Singh wants to ask that is there any advantage or disadvantages of administration beyond 96 hours?
The young woman, thank you for that question. The young woman with enterovirus-induced ARDS, we gave her the dosing regimen for approximately 9 days. And we never saw any problem. And you saw the effect. That was one of the chest films that I showed just as I was completing.
Dr. Swagata Tripathi wants to know that she would like to understand what the researchers feel about the importance of early patient selection, the criteria of selecting an intubated patients with PF ratio less than 300 within 24 hours of onset seems stringent, reflected perhaps in the low percentage of the recruitment.
Thank you so much for that question. The CITRIS trial was sponsored by the NIH. And we had to go to the NIH with very carefully defined criteria because we were doing an ARDS trial, a sepsis-induced ARDS trial. And when we submitted our protocol that we created to the NIH, we wanted to make sure, because we knew there would be a lot of critical care doctors who were on this panel, we wanted to be very careful about creating the criteria. Since that time, we've loosened up the criteria. So a patient coming in with septic shock, we give vitamin C. And as you all know, not every patient who develops ARDS is going to be intubated on a ventilator. They may be on face mask ventilation, non-invasive ventilation for the entire duration. And I thank her for asking that question. We simply had to create very strict defining criteria for patients with ARDS simply because it went to the NIH.
Any instances for hyperoxaluria and nephrolithiasis?
We have found no incidents of nephrolithiasis. I will mention that we are now engaged in another sepsis trial with the, as I mentioned, the PEDAL network. It's a lung injury network through the NIH. And that came up very, very prominently because there were a lot of people out there who were just convinced that there would be oxalate stones that would be formed during the 4 days or 5 days of treatment. And so we eliminated any patient who had, in this new trial, we are eliminating patients who have recently the acute onset of a kidney stone or who have had kidney stones in the past simply to get around the problem of the possible formation of oxalate stones. The stone that will get people out of the trial is specifically an oxalate stone. Calcium stones do not get you out of the trial. So I just wanted, it's just part of, again, the NIH being very careful with the possible complications. But we never, ever in all of our, like now over 500 patients, saw any nephrolithiasis as a consequence of giving vitamin C in this protocol.
Another question, any contraindication for treatment with vitamin C in sepsis? I don't think so. There is any contraindication.
I can't, I'm just, obviously an allergic condition to vitamin C. This one patient, honestly, we had to screen for patients who were allergic to vitamin C. And we did find one patient who had some sort of allergy. And so that patient was screened out of the CITRIS trial.
So few more questions, then we come to all the panelists that what should be the dose modification? Is there any dose modification in patients with AKI or in CKD patients?
I say no.
Yeah.
I can just tell you, we followed very carefully the SOFA score in these patients. And You know, the typical septic shock patient whose creatinine is already at 2.5, the septic shock patient who's oliguric. We still get vitamin C to those patients, and very frequently we started seeing the creatinine coming down and the urine output going up. So even in those patients from that question, we would still administer vitamin C. And we also gave it to patients on hemodialysis. And the only unfortunate thing about hemodialysis is it does clear the plasma level to some extent. And I would like to make one final point, and somebody may bring this up. When you're giving vitamin C intravenously in these levels, as you all know, every nurse that's at the bedside wants to know what the blood glucose is. That's in the back of their minds all the time. And point of care device, you immediately know what the blood glucose is. The unfortunate thing is ascorbic acid influences the point of care device, which analyzes blood glucose by a glucose oxidase system. And it can cause the ascorbate, when it goes up very high in the plasma level, bedside point of care devices will read astronomical high plasma glucoses. And so when we eliminated point of care analysis of blood glucose at the bedside in patients who were on vitamin C, and could only be analyzing blood glucose by the central laboratory, which uses a completely different enzyme system called the hexokinase analysis system. And that is not affected by the plasma ascorbate levels. There are some blood gas machines specifically made by a company called Radiometer. You may have heard of that company before.
Yeah.
That company can produce a blood gas as well as a blood glucose analysis that is not affected. But the point of care devices, such as you may have heard AccuCheck at the bedside, while patients are receiving this level of vitamin C infusion, central laboratory only for blood glucose analysis.
So this is a very important point, because otherwise everybody will be disturbed by the high glucose in such
Exactly.
patients.
And could be put on an insulin drip when
Yeah.
they may have a blood glucose level that's normal.
Thank you very much for highlighting this point. Dr. Prashant Nasa from Dubai wants to say something.
Yes.
Nasa, please.
Thank you, Dr. Deepak. Thank you, Professor. It was an excellent presentation, and
Thank you.
we were, got a great insight from your CITRIS-ALI trial. I think one of the major trial which looked at the higher doses versus the other trials which have looked upon smaller doses, and especially that THAT combination, which all failed to show any outcome difference. So what you recommend is a higher dose is sufficient, is significantly better in terms of mortality difference, and we should try for a higher dose. Probably in the future, researchers should try for a higher dose vitamin C. So my question is, have you ever gone back to your animal studies to look at the optimum therapeutic concentration where it can be effective, so that we can plan a future research on a optimum IV drug dose, rather than going out less than 10 gram versus more than 10 gram, that what is being recommended at present. So we don't know at present whether it's only 200 milligram which is really effective, or it may be another higher dose which may be found beneficial later on. So have we going back to the animal studies to find an optimal therapeutic concentration? I think that's question number one. The second question is about hypernatremia, because this particularly came up with that Chinese trial which was prematurely terminated, and they found higher incidence of hypernatremia with use of even 1.5 gram 6-hourly dose of less than 10 gram dose. And did you find the same thing to happen in your patients, or did you follow something different as compared to that trial? Thank you.
We did not find hypernatremia, and we have not gone back to the animal model to determine what an effective blood concentration was needed. I think in the Chinese trial, it may have been the vitamin C preparation that was used. We, as I mentioned, were using the product from McGuff Laboratories, very carefully designed and approved for use by the FDA in the United States. We never saw hypernatremia in any of these patients. As you all know, depending upon free water depletion in patients who are septic, the initial plasma sodium concentration is going to be elevated, but we did not see in our patients we treated, as a consequence of the dosage that we used, hypernatremia. But thank you very much. I think it may be just the preparation of sodium in the ascorbate preparation.
Sorry, just continuation of the same question. What was the diluent you used for vitamin C in your trial?
Okay, thank you for that question. For the trial, we would use the weight-based dosing, 50 milligrams per kilogram, would be placed in 50 cc's of dextrose, 5% in water, just a small bag, and we would infuse that over 30 minutes. And that would infuse usually through a central line, but it can be given through a peripheral line without any difficulty every 6 hours for 96 hours. The new trial that I mentioned that we are enrolling in, patients will receive for 5 days as opposed to only 4 days. But in a 50 ml bag.
Dr. Bharat, please, you want to say something?
Thank you, Dr. Govil, and thanks, Professor Fowler, for that excellent talk. You've taken us through the whole journey of, starting from animal models to the biological rationale and so on. I don't have a question, but I just wanted to add a couple of quick points. One is that, you've spoken about the clinical evidence. You clearly made that distinction between had doses and the higher dose that we're giving. There have been two recent systematic reviews of interest, both very recently published in Critical Care Medicine. So one of them looked at the effect of vitamin C as such in all critically ill patients. And overall, they had about 15 trials, did not find a difference in terms of mortality, but they did find that, the trials that gave a higher vitamin C dose, such as yours, suggested that there was some trend towards improvement in mortality. And that was one important finding that they had. They couldn't see a difference between septic and non-septic patients, but certainly higher dose seemed to be helpful. The other systematic review looked purely at septic patients, and in this trial again, in this systematic review again, no difference in mortality. But interestingly, they did show that SOFA scores were lower and vasopressor-free time was higher with vitamin C.
Right.
My only concluding point is, I think there is biological rationale. I think that you've demonstrated that nicely with CITRIS-ALI, but I remain skeptical still, and I think that a larger trial still needs to definitively answer the question whether more than 10 grams is going to be helpful or not. I think there is enough data to suggest that this might be the case. There is a hypothesis, but I still remain skeptical, and I think a larger trial, and there is at least one or two out there, including Lovett, which hopefully will give us some more answers. Thank you.
I think you made such excellent points because this is something completely new in critical care. And, I'm now 72 years old and I've been doing this for a long time. And during my years of being an active critical care doctor, I sat with many families as we described the end in patients who were dying. And as all of you know, we lose a lot of people, even though we have multimodality therapy. And coming out of the blue, CITRIS-ALI to suggest that there might be a change obviously was important. But I agree with you. Any move in the future needs to be done confirmatory with new randomized, controlled, placebo-controlled trials. I am a clinical trialist. I have always been a clinical trialist, and you don't just accept what some guy says as truth, that you do a study to determine if it really is effective. The CITRIS trial, it was effective. It was blinded and it was multi-center. And so the value of multi-center is Somebody in Cleveland practices critical care different than somebody in Richmond, Virginia, different from somebody in Milwaukee, Wisconsin, different from Atlanta, Georgia. And so the critical care practitioners coming from different angles in the care of septic patients is the value of a multi-center trial. And if the Lovett trial that you're conducting in India hopefully is multi-center and that it will reveal something. I about 6 years ago flew to Toronto, Canada, and met with the people who were planning the Lovett trial, and they were using the VCU protocol. But thank you for making that point. I totally and completely agree.
Dr. Rangappa, would you highlight some of your experience and any comments, questions?
Thank you, Deepak. Thank you, Dr. Fowler, for the excellent presentation. So we have been using vitamin C for quite some time, and we were hugely enthusiastic at the outset when the CITRIS-ALI came and the previous studies by you as well, and a few other positive trials. But then that enthusiasm sort of faded, Dr. Fowler, in the light of the 3 recent trials that came, the Vitamins, Victus, and ACTS trial. And the only difference we see, as cited by my previous panelists, is the dosage difference, because all these 3 trials that has come recently has used 100 mg per kg as opposed to 200 mg that you have used. So it would be interesting to note that is it only the dose that you have been citing which has possibly made a difference? Because even in CITRIS-ALI, Dr. Fowler, we did not see a difference in the SOFA score nor the inflammatory markers, and the mortality was only a secondary endpoint. And in the discussion, I think you yourself have mentioned that this was underpowered for the change in SOFA and biomarkers. So would that raise sort of, and even surviving sepsis guidelines, which lot of our practitioners would follow, has de-emphasized on this molecule. So I agree with everyone that we need to look at more data, the future studies that would possibly give us more answer. That's my first comment. And the second one would be, would thiamine, which has been predominantly used to reduce oxalate, although you have said that more than 40 grams per day would cause oxalate deposition. I think in one of your study, you have cited more than 40 grams per day would cause oxalate. And thiamine, which we were using in, and many trials have used, is that the reason that to reduce the oxalate is one of the thought process? So would you suggest, or would you say that thiamine doesn't need to be, and even many studies have shown that thiamine levels are low in sepsis? So that is my second question or a comment. And the oncology, third one, I'll end with the third question. Some of the oncologists have a lot of apprehension about using vitamin C because they look at it as a diabolical molecule. Albeit you said during your presentation that it has helped in oncology patients, leukemia and other conditions, but some of our oncologists have raised concerns that it may hasten the metastasis because of the extensive cell mitosis that happens, or cell multiplication, because it is helpful for cell replication. So these are my comments and observations and need clarification. Thanks, Dr. Deepak.
Okay, let me comment on those great suggestions. All right, so first, thiamine is harmless, and giving a couple of 100 milligrams of thiamine a day, I have no objection to that. A fellow that is actually not too far from Virginia Commonwealth University at Eastern Virginia Medical School, a fellow named Paul Merrick, came up with this protocol giving thiamine with hydrocortisone. As you know, the HAT therapy has been proven not to be effective in placebo-controlled trials. I have a number of friends at vitamin C institutes, one important institute at Kansas University. Oncology doctors there, get ready for this, give 100 grams of intravenous vitamin C twice a day, Monday, Wednesday, and Friday. And you can see about the levels that occur there. And their rationale is that if they get the levels of plasma very, very high, that they can cause tumor cells to basically kill themselves. Tumor cells have various enzyme deficiencies, and it's been postulated that some enzyme deficiency that would enable vitamin C to generate a huge amount of hydrogen peroxide intracellularly kills tumor cells, whereas it does not kill normal human cells. The enzyme system is called catalase, which cells use to protect themselves against the formation of hydrogen peroxide and other reactive oxygen species. And tumor cells, for example, from pancreatic carcinoma cells, are bereft of catalase to be able to protect themselves from reactive oxygen intermediates intracellular, and high doses of vitamin C can concentrate vitamin C because of those transporters that I mentioned intracellular, and it kills tumor cells. Even with all that said, and oncologists who have made a career using vitamin C to treat certain cancers, it's still not out there as the preferred form of therapy. So I have no objections to giving thiamine. I mean, I think it's a harmless drug, giving the vitamin C in the concentrations that I have mentioned. But as was mentioned by Dr. Kumar earlier, I think it's very important as we move forward is that additional trials need to be done. I'm aware that the sepsis guidelines said that there is weak evidence to support vitamin C. Obviously, I disagree and feel that we should press on. The current trial that we're doing with the PEDAL network was using the VCU protocol. We will be enrolling 900 patients, and we should have the completion of the trial within a year and a half, and then we'll publish the results.
Dr. Anup, your comments, any point of discussion would you like to highlight here? Or want to share your experience?
Hello. Thank you, Dr. Fowler, for that excellent presentation. Few points I would like to ask are, like, do you feel there is any specific role for this high-dose vitamin C in hyperinflammatory response seen in COVID patients? Your comments on that. And again, like the duration of vitamin C therapy, especially when we have these hyperinflammatory response, is there any point in continuing this vitamin therapy for more days? And another thing, what I observed during my practice is there is higher incidence of hyperkalemia, especially when we are using for patients with even with mild renal impairment, maybe because of the preparation what we are using here. So I would like to hear your comments on that.
Okay, thank you very much for those questions. We are in the midst of doing a trial. We are blinded because we are testing the VCU protocol that I have been mentioning in patients with COVID pneumonia and respiratory failure. We have enrolled 50 patients in the trial thus far. And even though we're blinded, some of these patients are recovering quickly. I will relate to you a husband and a wife who acquired COVID pneumonia for attending a wedding. And they were acutely admitted to the VCU Medical Center, and we got consent from both of them to enter the vitamin C COVID pneumonia trial. And within a day and a half, the husband showed a dramatic improvement in lung injury. And unfortunately, the wife went on to die in multiple organ failure. And again, it was a 1-to-1 ratio. I don't know if vitamin C was used in the husband and promoted his survival, but we definitely saw that. And your next question was about
duration of therapy.
The duration of therapy. CITRIS trial was 4 days. The ASTER trial, which is going to be, it is a 3-arm trial. One arm will be intravenous acetaminophen, which is a potent antioxidant in patients with sepsis. The other arm is going to be our protocol giving vitamin C. Both of these treatment arms will be 5 days. And then we have a placebo arm. And that is now started. It's called the ASTER trial. And we'll be working on it for the next year and a half. And we will see if, as I mentioned, in the young woman with enterovirus-induced ARDS, we gave her 9 days of therapy at the dosage range that I mentioned.
I hope Professor Fowler has cleared your question very well. Dr. Bora, would you like to comment? Please comment some.
Hello.
Please, share some experience or comment your comments.
Yeah, actually, very thankful to Dr. Fowler for elaborate explanation about the role of vitamin C in sepsis. See, it's so vivid that he, starting from that mouse trial up to a living patient trial, everything is so vivid and so, encouraging and reassuring, because the flow of the discussion is so smooth. Lots of even my doubts are being cleared. And few comment. One is like in our childhood days, we used to hear one say, too much of everything is bad. Now, that is our childhood. Too much of everything is bad. Okay. So when
that's candy.
Yes, sir. Then I see what is the normal dose requirement of vitamin C. It says 100 mg only. Then if you say in some situation 2 gram, not more than 2 gram, it's enough vitamin C for a person. Now coming to this therapy, it is quite a dose, but I don't know how much is too much. Now from your presentation, one thing is very clear that yes, it is beneficial, number one. That is what I can feel, that yes, it is beneficial because you have clearly shown the benefit. Now question is regarding the dose. I think forget about it as of now, because as we intensivist, seeing lots of people are dying every day, every month. I have been working in ICU for last 16 years. I have seen thousands of patients dying.
Lots of death.
Correct, sir. And that is a point where I agree with you totally, because it's a drug which is not, lethal. It's not a toxic drug. It's not a toxin. If you give, even if it doesn't work, it will not kill the person. And question about whether it will work or not, we have evidence. You have showed me the 20x view of the action. That is clear-cut evidence that it is working. So as of now, I don't care about that. Only thing I care about a patient. If I can save one life, that is, I think, biggest achievement in my career, in my life. In the first slide, you have shown 2 big Boeing crashing per day. Can you imagine that thing? But we are actually not seeing that. But if a flight crashes, 416 passengers will die, and that will be in the news for another 1 month.
Exactly.
Continuous, non-stop, all channels, all over the world.
And if it's 2,
yes, sir.
2 747s crash every day with over 800 people every day.
Right.
Boeing would go out of business.
And we are not talking about it. That is the biggest thing. We are not talking about those millions, but we are talking about.
Problem. That's the problem with sepsis, isn't it? Because the people of concern, such as yourself and your colleagues, deal with death every day. And somebody might read about one of their friends as an obituary in the newspaper. Probably never mentions that the patient died of septic shock and multiple organ failure. The people who really know it are us as critical care doctors.
Yes, sir. Absolutely right. Absolutely agree with you. And I hope we'll come up with more study and more robust things so that we will be more confident in dealing such kind of a situation. Thank you, sir.
Can I also also mention, vitamin C is not mentioned as a single drug in an intensive care unit patient. You may still have that patient on 3 antibiotics, on whatever vasopressor is working to support the circulation, mechanical ventilation, and other techniques to support patients with critical illness. Vitamin C is just an added part of the regimen. It's not intended to be the only therapy. It is part of a combined approach to take care of a patient with sepsis and organ failure.
Yes, sir. Absolutely agree, sir.
Thank you. And thank you for your comments.
Now I request Dr. Bharat Kumar to share his experience. He already want to say something. So Dr. Bharat Kumar, over to you.
Thank you, Professor Govind. Maybe just 2 minutes to explain, the program of research that we have been undertaking. This is called the LOVIT umbrella program. LOVIT stands for Lessening of Organ Dysfunction with Vitamin C. This is a multi-country, multi-platform kind of a program. So the umbrella trial has the main LOVIT trial, which actually has completed enrollment of 872 patients from Canada and New Zealand. There is LOVIT ARDS, which is going to be done in France. This trial will be led by Professor Anand, which will also include 800 patients with ARDS, similar to the PETAL network. So there will be about 800 patients, but purely of ARDS. There is LOVIT COVID, which has enrolled about 300 patients to date, looking specifically at the Dr. Fowler's dose in patients with COVID-19. So we'll have some answers there. And LOVIT COVID is enrolling in partnership with REMAP-CAP. So hopefully we'll have some answers very quickly.
Okay. And the PETAL network is also working with REMAP.
With them, yeah. So that should hopefully answer some questions. And in India, we've been doing an independent LOVIT India trial, the aim of which was essentially only a pilot feasibility trial. So it's a small trial. We're going to enroll about 50 patients in India. We've enrolled 28 so far. And hopefully in the next couple of months, we should get to our target. All of these trials, the proposal is to do an individual patient level data meta-analysis, which will combine the data from all of these trials. So we should have about almost, putting all the trials together, 2,000 or 2,500 odd patients, which will be combined into an IPDMA. So maybe we will shed some more light and there'll be more patients that can provide answers. So that's the status of the LOVIT program. Thank you.
And I think your comments are so well taken in that the comments that occurred from you earlier is the only way vitamin C can make its entrance and acceptability into the care of critically ill people are through randomized controlled trials, which I am totally supportive of, and all of my colleagues and my team here at VCU are also.
Thank you, Professor Fowler, Dr. Bharat Kumar, Dr. Pradeep Rangappa, Dr. Nasa, Dr. Abul Bora, and Dr. Anup Kumar. There is a constant stream of questions. We are already exceeded our time, but I would like to highlight one or two questions from Professor Fowler. That Dr. Ankit Sharma has asked, good evening, sir. There are reports of increased liver enzymes with high dose of vitamin C. Does it warrant any concern?
For me, it does not bar any concern. We never saw any impact on liver function other than the impact of sepsis on liver function.
Another question, does IV vitamin C can cause diarrhea?
No, it is the oral consumption of large amounts of vitamin C that cause diarrhea. And the other thing I didn't mention, the reason that there are 2 active transporters for vitamin C. In the vascular space, it's sodium vitamin C transporter 2. But on the GI tract, it's sodium vitamin C transporter 1. And even though you're taking multiple grams of vitamin C, sodium vitamin C transporter 1 in the GI tract is rapidly maxed out and cannot transport more than 200 micromolar into the plasma. And that was very well shown in 2006 by Dr. Patayati and colleagues that gave it both oral and intravenous in varying doses. But huge amounts of vitamin C orally will promote diarrhea.
Dr. Rangappa, Dr. Nasa, Dr. Anup, Dr. Apurv, any other question, any other point of discussion? Would you like to say something?
So with your permission, one last comment. If it's okay. Dr. Govil?
Yes,
With your
please.
permission, one last comment.
Yeah, why not, please?
We have not talked about vitamin C induced hemolysis, especially in the patients with G6PD deficiency. Any experience with that, or do you recommend as a screening tool, especially when we are using such high doses?
Yes, I recommend G6PD analysis.
Just one last comment, Dr. Govil, if I have permission.
Yes, please.
Professor Fowler, I think there are a few studies earlier on where it has shown that vitamin C is very good in maintaining endothelial integrity. And you did mention monitoring of syndicant with this EGL end product. So I think even if mortality is a far-fetched thing, at least if it minimizes our fluid resuscitation and the over-resuscitation, that may be a huge benefit, because there was a study in burns by Tanaka et al. Where they used the 66 milligram per kg vitamin C, and they showed significant reduction in the fluid resuscitation goals.
Exactly.
And this may be useful for our Indian dengue patients. So that would be exciting for us if it can reduce. And we were proposing to do this study in our dengue patients. Dr. Your comments on this?
I'm glad you brought that up. Takada and colleagues from Japan did a study in burn patients with 50% full thickness burns. And what they showed, typically a burn physician taking care of that kind of burn is going to give huge amounts of fluid over the first 24 to 48 hours. And what they found was the amount of fluid resuscitation in a 50% full thickness burn was reduced by 50%. And so we partially worked this out in our laboratory. And what we showed was that endothelial cells in culture, which we had in our laboratory, if we put varying concentrations of vitamin C in the different wells, would cause the endothelial cells to swell. And part of the therapy of vitamin C is the effect that it has on the endothelium. And as everybody knows, the endothelium draws back in active sepsis, and there is free flow of fluid into the extracellular space. And vitamin C, part of its magic is that it causes the endothelium to swell, and it prevents that movement in flagrant high-grade sepsis. Thank you for making that point about the burns.
So with this, I would like to thank Professor Fowler, Dr. Pradeep Rangappa, Dr. Prashant Nasa, Dr. Bharat Kumar, Dr. Anup Kumar, Dr. Apurv Vora for excellent discussion, and especially Professor Fowler for excellent presentation. And side by side, I would like to thank all the attendees who took out their time and joined us today and helped steering this discussion, because this discussion could happen because of their questions and their interaction only.
I would also just like to thank you again for this. It's such an honor to speak to you and to hopefully tell you about new ideas that can come to fruition in the care of patients with sepsis and organ failure from sepsis.
Side by side, I would like to thank Messrs. Delvin Specialties for supporting this webinar also. Thank you very much. Good night. Have a safe night. Thank you. Bye-bye.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you, Dr. Govind. Thank you, everyone.
Good night.
Thank you.
Good night.